St. Joe's previously. We opened up imaging services, and that was another shared service. 2 MRIs, CT, ultrasound, fluoroscopy, and diagnostic radiology. In the lower level, we opened up a laboratory, also was a shared service, and physician on-call rooms. And then we left a lot of shelved space in the facility, so we have room to grow in the future. So before the tower, in terms of what we had for informatics, we had electronic clinical documentation. We had bedside medical device integration, so we were pulling vital signs off the monitors in the critical care areas. We had computerized provider order entry, and I'm always really proud to say that we managed to maintain 97% to 99% of orders entered by providers for years. We have pharmacy, inpatient and outpatient, and we had ambulatory clinics that were live with both CPOE, the medical assistant documentation, the nurses documentation, and the providers documentation. So fully live in the ambulatory arena. The shared services that we had with St. Joe's, I'll run through them one more time because I think it's important, were laboratory, radiology, emergency department, and surgery. And to manage those shared services, we had bidirectional interfaces, which could be a nightmare at times, for both orders and results. So our CPOE orders went over to St. Joe's and the results came back. We had paper records for surgery and the emergency department. So there were a lot of major new systems that we built into the new South Tower. PACS, and we had 2 PACS, one for cardiology, one for radiology. FirstNet, which is an emergency department system. SurgiNet, and we did both anesthesia and perioperative documentation. Instrument tracking and tissue tracking. EndoWorks. PathNet, which is the laboratory system with specimen collection and bridge transfusion. RadNet, which is the radiology system. We also implemented a blood and donor system. Studio 3, which brings images from pathology back into the OR, and capacity management, which replaced our old bedboard and dispatches transfers, and EVS. So there are a lot of systems, and I'm going to just pull this slide all the way up, and then I'll talk about it a little bit. A lot of systems that support patient care. Cerner Millennium is our primary database. And in Cerner Millennium, we already had PowerChart. We added on SurgiNet, as I said, with tissue tracking, instrument tracking. So I'm not going to go through each piece of this slide, but I think it's important to be able to see the number of interacting systems that we were using. And this slide, I think, really shows the complexity of how the device ecosystem works and the complexity with which everything is having to talk to each other. Integration is a wonderful thing, and it's an awful thing, so it can be both. So the build for all of these systems largely was consultants and vendor build. We contracted with Cerner to do it. That was both by need and by design, because at the time that we were building these systems, we didn't have end users, because remember, these departments were all new and had previously been at St. Joe's. So we didn't have the luxury of bringing in a group of subject matter experts, and at least initially, we largely depended upon the directors. That was good in a lot of ways. We ended up with some really good, solid systems, and in other ways, it wasn't. I think when Frank Maas gets up here and talks to you about the emergency department, he's very cognizant of the fact that we built it on their backs because they were trying to build departments and we were trying to build software. So we also, at the time that we were doing the build, had major concurrent projects. We had our ambulatory project, and we just recently went live in our primary care clinics. Positive Patient ID, which is the barcode meds administration, went live with that house-wide while we were doing the tower. 724, which is a downtime system, and then just that little minor thing called meaningful use. One of the things that became apparent very early on is the challenges that we would have with integration with our existing build and trying to make sure that everything talked to each other at the end and that we had a seamless record for the patient. Surgery needed a surgery record, but we needed to make sure that the nurse who took the patient after surgery was through could see what had happened. So we really worked hard with the departments to try and accomplish that integration. Oops. Going the wrong way. Don't want to go back to that slide. So then we created what we called parallel processes. We did gradual go-lives from February through March of this year. So we went live first with laboratory, and then we went with radiology, and with radiology we had to do anesthesia, and then we did the operating room and brought those up gradually. So during this time, we were having to, I don't want to say play with, but that's pretty much what it was. We were having to play with all of the interfaces and make sure that the orders got to the right place. So one day when you entered a lab order, it went to St. Joe's, and the next day when you entered a lab order, it went to our new PathNet system. But the radiology order still had to go to St. Joe's. So it became a very complex system that required a lot of education for end users. It required operational and information system command centers for a full 2 months. And workflows were changing as each new system went live. So super users and daily huddles were really the answer, and they helped a lot. All interfaces are off now except for a few for what we call persistent shared services with St. Joe's. That's like nuclear medicine and a couple of other things. So as I was thinking about this talk, one of the things that occurred to me is that if these two people on this teeter-totter are end users, one who didn't know enough and the other one who got too much information to remember, the super user in the middle is the one who really balanced that out. So we really worked to make sure super users are comfortable and ended up using what we called in the past our super duper users, which is the informatics team, to assist with that. Made a big difference. I'm not going to read through all of Cotter's 8-step change model. I think everybody in this room probably is fairly familiar with it, but it really is something that we ended up doing. We created urgency for sure. The tower was going to open whether we were ready or not. We created a vision. We got our powerful coalition. And anchoring the change in corporate culture, I think we're still doing the anchoring on that piece because we're still refining and trying to get things to be precisely right in all of the software to support everything that needs to be supported. I found this blog when I was thinking about change, and he said a change agent is someone who alters human capability or organizational systems to achieve a higher degree of either output or self-actualization. Beginning with the end in mind, the goal of a change agent is obviously to make changes that stick. So on that note, I'd like to introduce you to 3 of the change agents from CHOC. And if you'll just raise your hand when I call your name. Louise White has over 34 years of international healthcare experience. Originally trained in the United Kingdom, Ms. White has spent most of her healthcare career in various clinical and management positions throughout the U.S. healthcare system. She has extensive experience in clinical and research arena, as well as over 20 years as a hospital executive, and we are fortunate to have her as Vice President of Patient Care Services here at CHOC and Chief Nursing Officer. Frank Maas has almost 35 years experience in the emergency department, both clinically and for the last 24 years in director roles in inner city, academic, community, and now pediatric emergency settings. Frank has worked with industry and government organizations in the area of emergency, patient care, medication safety, and staffing, and has been involved in developing legislation regarding the provision of emergency services. We are fortunate to have Frank as the director of our emergency department. Melanie Patterson is currently a nurse leader at CHOC Children's. She started her career at CHOC, was recruited away, and then we got her back because she loved kids so much. In 1999, City of Hope recruited her to help develop their pediatric program. During her tenure there, she led several units and also managed the new assumptions of a major medical center move. Melanie is in her role at CHOC Children's as the executive director for activation in South Tower. So with that said, I would like to ask Melanie to come up and tell us a little bit more about the activation.
Thank you, Ruth. So I'm going to apologize now because I have a squeaky voice, and this is not usually my voice. You can ask anybody at CHOC, but I've saved it for just this afternoon. So as Ruth said, my name is Melanie Patterson, Executive Director of Activation of South Tower, and that's been such a great privilege and opportunity for me. I'm a nurse leader working in the clinical leadership project management concept, which means they moved me to the construction trailer, and I work partners with the construction management team, construction, and also build bridges between operations and construction. So it's been a really fun, exciting 18 months. I'm directly responsible for achieving critical path deliverables in key areas of the new services in the Bill Holmes Tower, including planning, procurement of equipment, licensure, and activation. And I manage the transition plan, and I will show you the transition plan later. So activation, what did we do? And Ruth went through the different areas of the South Tower, but I'd like to talk about what that meant when we're moving into the South Tower. We activated all services, all those services that Ruth talked about successfully, along with a family resource floor, on time and on budget. We had a 2-day CDPH survey for the entire house that we passed with no follow-ups at all. They left that day and said, "You're ready to go." We also built, and I don't think Ruth mentioned this, but we built a NICU at St. Joseph's Hospital. And a week into our activation, we decided to open that unit too, but we need to license it first. So we had CDPH here that morning. They were here for an hour. They licensed us in an hour. And within about 4 or 5 hours later, we moved 9 patients over. So we licensed and activated that unit on the same day with the incredible NICU leadership team. Frank led a comprehensive Children's Emergency Center survey, so we received our pediatric designation within a couple hours because of the great work that team was doing. We had to stop and celebrate several times. One celebration was about 3,000 people, our community. We actually blocked off La Vida, and if you're from the area, you know just how significant that is. It's the street straight to May Place, the shopping center. So we blocked that out. We had 3,000 people here to celebrate, and 2 days later, we opened up the second floor. So we had incredible plan ops and EVS that turned that place around so we could activate. Many media days, which we had media come in and see our area, and lots of interviewing so we could get our information out to the community. Our teams hired 576 new hires. That's hiring a whole hospital within the last 6 months. That means that they hired, they interviewed, they hired, they onboarded, and they trained almost 600 people within that time while we were activating a new building. The leadership team had 240 plus tactics. Those are goals that I manage in that group, and we're on time with the tactics and on budget. So how did we do that? Well, you start with assumptions when you have a project like this. But first in 2006, so 7 years ago, we had some leaders and a great safety leader, Dr. Jim Capon, who came up with the idea of having a meeting of the minds to look at the safety and the opportunities that we'd have as we build this new building, this new tower. And so for 24 hours, we had 35 people, 35 facilitators and hosts, 35 tables in this room, actually. And for 24 hours, we asked all of our staff to come in, sit at a table designated for certain things like inpatient units or radiology. And we talked about what their ideas were for safety and what things they would like to see in the new building. we had over 2,000 ideas, and many of them were active failure ideas, such as clinical alarms or communication, patient flow. Others were more latent conditions, such as distractions, noise control. So they had a lot of ideas, even about lighting. When you walk into a patient room, what does the lighting need to look like for that night nurse who needs to see everything but doesn't want to wake up the family? So we did that. We took all those. He did a lot of work with those ideas, and we were able to integrate many of them into the planning process of the new building. So we started with assumptions. We had a lot of them. I think we have 20 plus operating manuals. And those operating manuals, they look at all these things up here on this PowerPoint slide: timing of deliverables, volumes. What do the volumes look like in the ED? What are we going to expect when we open? What are the programs? Are we going to do everything? Are we going to commit to doing everything as we open up this tower? Types of treatment, workflow, processes, systems, staffing, support service infrastructure. It's not only about the ED or the OR or oncology. It's about all those people that are working in those areas, and what kind of infrastructure do we need for those people. And parking and wayfinding, which was like a month project on how many spots do we have in our parking garage? Can we accommodate this, and do we need to build a new garage? And so it went from the very broad to the very detailed of work, and all of that's recorded in what we call our operating manuals. I wanted to share our activation functional chart, because I think this is important if any of you are ever going to be involved in a project like this, which I don't think any of us will ever be involved in a project such as this, as big as this, because we opened a new hospital while we were activating one. And pretty incredible. So I'm sorry you really can't read what this is. This is really our structure of how we managed. I'll call it our governance structure, how we made decisions. And what you see down here is, and I'm happy to go over this later. If you want to meet in the back, I'll talk to you. But these were all of our deliverables. And they're tower goals, input from Cerner Build, policies, procedures, operating manuals, modeling, simulations, day in the life, scenarios, training modules. Over here is really the cascading chain of command. So you start with execution. All these, we had 22 teams here that were meeting all the time. And when Frank comes up, he's going to say that we were in meetings constantly. I'm not going to take away his thunder, but we were in meetings constantly. Everybody met, all the support services, all the people that were here in the departments. And then we had subgroups, and those subgroups were like onboarding and training, staffing, communications, tower technology, policy and procedures, and all of that rolled up to the project management team. This is myself, and I had a partner, Melissa Sam, from the Jacobs Construction Management team. And so we partnered to make sure everybody had what they needed. And then we reported to the operating parameters and project leadership team, and then CHOC activation team. So this is really, for several years, how we functioned. And about a year ago, we were all complaining that we were in meetings all the time, and that we really couldn't get the work done that we needed to get done. So we re-looked at what we did, and I think that's an important point, that as your project progresses, you can't forget about the governance structure and how you're making decisions, and does it really make sense? And so we had the opportunity to sit down and think about, is what we're doing really making sense to our deliverables? And so we re-looked at that. We looked at we looked at the clinical operations and just looked at the major areas: ED, OR, hematology, oncology, radiology. And what we did is we asked the support services to attend these meetings instead of those directors attending every other meeting at very specific times in their agenda. And so it flowed very nicely. They always knew what the agendas were, and we got everything done. We also had some subgroups, but you can see that we, as you go up, some of this changed too. And we started an occupancy planning team, which really, in my opinion, was the best thing we did on the project about a year and a half ago. And that was really the vice presidents of the activation, so Louise White of Patient Care Services, Matt from Ancillary Services, Waldo is the construction, and Mark Headland for IT. And then we added others, Dr. Feaster, Informatics, and we met every week and looked at the issues and made decisions very quickly. That was really the best thing we did. And then we reported to PLT. So you can tell that our deliverables stayed the same, execution to oversight. But we were able to sunset all of these committees. We sunsetted, I would say, about 15 committees without any risk of not getting the work done. And as you know, in organizations, that's hard to do. And so in the middle of this, we were able to do that. So what were the challenges in this project for me personally, and I think for the people coming on, those directors leading these projects? New relationships. We've worked at CHOC for many years. We had new associates coming on, new leaders. We had new consultants coming on. We had construction. We had project management people. We had all kinds of new relationships we were trying to form while still operating a hospital. Right person, right job. And if you ever talk to me, I'm going to say this 100 times. The most important decision anybody makes in an organization is right person, right job. And it was something that we really needed to make sure we were doing. It's not easy when you're hiring almost 600 people. You get in a hurry. So, and I'll tell you, these directors did a bang-up job. We have some outstanding associates here at CHOC. Trying to eliminate the silos. So, as you're moving, CHOC has always been a community. We've always felt to be a mom and pop community hospital, children's hospital. We are growing up, and a lot of people were holding on tight to that mom and pop philosophy. And so trying to help people understand and take a step back at the broader vision, where do we want to be 2 years from now, and how can you help? So really, I'm going to go right into that managing up, helping those leaders that have been here for years and years say, it's okay to let go of this. It's going to be bigger and better, but to convince them of that was certainly a challenge. And then managing 241 tactics of the building with a variety of stakeholders. So that was several teams of people, certainly is a challenge. This is one of our master transition plans, and what you can see here, you can't see it, but it's a little blurry up there. This is really critical path, and so our license dates and everything's on that. And then tower activation, our phases. You can see over here in February, we started activating everything. Day in the life, if you don't know what that is simulations, and it's a whole building simulation. So we have people come in and help us simulate activities from the front door to transport in every area, and they're very, very big deals, but it was so worth. I think the first day in life we had, I had 300 issues to follow up on, so you can imagine. Then we have tower technology. I don't have my glasses on, so I have to read it here. Medical equipment, and then staffing and onboarding. And this is the wave of our hiring. So you can see over here in July, August, we had very few people here. We had very few people to do all that work. We had the directors here, but they had to hire. They had to think about competencies and training while they were trying to choose the right equipment, et cetera. So certainly something to think about. I would like to see a tsunami this way. If I did it again, I'd want to do that. But I know budget sort of curtails us of that. So that's the wave of hiring for us. And it worked. I mean, most of us are clinicians and work in the hospital, and we just make it work, right? It always works out. So the most important lesson for me, I'm going to go back to my philosophy of right person, right job, but I'm going to add right time. Because when you're really looking at this big project, you have to have the right person, right job at the right time. And I think if we really look at the project, we probably could have used some educators a little bit earlier to help us with the training and competency development, not the training. We had them here for training, but there's a lot that goes into all that competency, especially when you're bringing on all those nets, PathNet, FirstNet, SurgiNet. And so for successful outcomes, I would do the right person, right job, right time. Other lessons. Now, I am not IT. I am the farthest from IT as you can get as a nurse that I am trying to adopt. And I know all of you are IT. physicians here all night working on the activation, and then when we decided to turn it on, everybody just sort of held their breath. The other things that we did, I'll talk about in a minute, is a command center. Every time we activated, just like a HIMSS disaster command center, we had the same. And I'll talk about that in a minute. Beta projects. We had one beta project during this. It was Specimen Collect when we brought up PathNet. And looking back, probably wouldn't do a beta project in the middle of a huge project like this. We did have a little trouble with Specimen Collect, and it had more to do with the printers, not really the IT. And we got through it because the IT command center, we had 2 bullpens, IT and operations, and they were here every day. We had our Cerner partners here every day. We would meet up to 3 times a day if we needed to, just to get through the issues, so we didn't have any safety issues in patient care. And so although it worked, and within a week we were stable, it was a tough week for everybody during that time. Don't be in a hurry to decommission the command center or daily huddles. So we had 2 bullpens. We started with the command center with our first activation with lab, and really didn't shut down. We had some after hours, but when we were in full activation, we had 7-day-a-week command centers for almost 8 weeks, 2 different command centers, daily huddles every morning, Monday through Friday at 9 o'clock, where all directors would come in and we would talk about volume and our key performance indicators and see if there was any issues. If there was any issues, we dealt with them right there. We also had nurse informatics there, and so if we needed some training, they would come up with the training plans very quickly, and they would go out very fast and get the staff trained. So we really had some incredible partnerships during this time. And need infrastructure to communicate with the physicians. It's tough to communicate with physicians. They're very busy. They're all over the place. So I would recommend to you that if you're doing something like this, think about how you're going to communicate with the physicians. Think about biweekly physician meetings. And we did that. We were in there. We had opened, in the middle of this, we opened their own dining room. So we took advantage of that and had our vice presidents over there meeting with them. So I'm starting to lose my voice, so I'm going to get through it faster. We are still, Louise and the directors and I are meeting with physicians every other week with the contracted groups, because we do have contracted groups. We want to engage them, so we meet with them every other Tuesday evening still. So rewards. For me, it's organizationally and personally. Learning to manage the critical points in a project and not think that every point is critical. And know what is critical. So I think it's just I have learned some really good lessons during this time and how to identify those critical points. New experience, new knowledge. All of this is new knowledge for me and a new experience. And if you ever have the opportunity, take it, because it is an incredible experience. It helps all of us to have a broader vision. So again, we all get so caught up in our own little world, and to take a step back and look at broader, what does this mean? What do we want to look at like 2 years, 5 years, 10 years from now? And what can we do right now to help streamline in that direction? And then lifelong friendships and colleagues. I have made really, really fun relationships with the new directors, but also with the consultants coming in that I know that I will be friends with forever in my career. And with that, this is our first floor that Ruth talked about. I don't know if you can see that up there. So hopefully, I think you might have walked through it this morning. So thank you. Make sure that we were on track.
I'm Frank Maas, and I'm here representing the 4 major departments that opened up, the management that kind of got these things off the ground. There's a couple of things I'd like to say initially, though. None of this would have happened without the existing. We're sort of focusing on the new areas and the new building and the new departments and all of that. But without the existing departments, the existing facility, existing management, this never would have happened. So this has been a joint effort between all of us. And then I always like to answer the burning question that is, yes, I am actually a pirate. So when I came in the first part of September 2011, I came from a couple of previous experiences with building projects, and with a complete hospital, replacement hospital, a new emergency department, things like that in the past. However, this was the first time I stepped into the role of bringing one up from scratch. So we found initially that there were things that we were going to have to adapt to, build, implement, and integrate into the facility. And we knew that after that got done, we would have to go forward with, focusing on our operations, marketing, data collection and refinement, and future planning. The things that we had to adapt to, and as many of you may know, in California, it takes anywhere from 6 to 15 years. One of my facilities built a new hospital, spent 14 years getting from the day they decided to do it to the day they opened the hospital. It takes a long time. And one of the first things to happen is the floor plans are done and the architectural drawings are done. And so as we came on board, we were basically inheriting what was done, and that's appropriate, but you do have to learn to adapt to it. Also, the initial budget assumptions about what we're going to do, they had groupthink type equipment planning that included a lot of folks, but not very many from the emergency department in our case. Looking at the practices and policies of the hospital that existed and how we were going to integrate into that and what the MR platform was going to be, in this case Cerner, was already being used in the hospital, and we were taking up the new nets or the individual department units on that. And then we had to look at the culture of the existing hospital, how people interacted with each other, how things got done, who was who, and how they responded to each other. So those were all important things that we had to learn kind of really early on. When we looked at what had to be built, it was staffing, the MR platform, the equipment list, the supply chain items, policies and procedures, flows and processes, utilization of space, and many other things from scratch. So we had empty books. With the staffing, as Melanie showed you in her slide, there was sort of this, it started with us. In other words, the directors were here and we were sort of it. And then it moved up there, up to shortly before the opening, where it sort of peaked out a few months before the opening. For that, we had to come up with the job descriptions, the order that we wanted to bring people on board. In other words, each time looking at what the next most important group to help get the place open were going to be, and what the timing was, because you had to balance the budget against how soon you brought people on. It would have been nice to bring everybody on and let them practice for 2 years. That's not going to happen. So we got 6 to 8 weeks to do that in the emergency department with our staff. Onboarding, we developed training and then coordinated with the different folks for the different elements of the training. We built a lot of it in the department that was ED specific and relied on others to help us with the Cerner training, and different general policy trainings, and to get the staff acclimated to the facility. How are we going to do that? How are we going to get them used to where they went for what they needed? That sort of thing. We also developed our plans for retention and rejection. Usually you don't see those two together, but when you put a whole new staff together, in the ED's case, 100 and some odd people with the part-times and the per diems, you know that even through your best efforts, not everyone's a fit. And so you have to be prepared to act early, use your first 90 days or whatever your policies are in your individual facilities to make sure that people are fits and then ease them out if they're not, while trying to maintain staff satisfaction with the rest of the folks, and we're trying real hard to maintain that. With the Cerner FirstNet build, suddenly I'm an expert. It means that I went through a couple of builds in the past, none of them were named Cerner. And even though they're similar, builds are similar, they're very different from each other also. So we spent a lot of time in the exotic city of Kansas City, Missouri, going back and forth there, and as large groups to work with Cerner, and then working with them on site constantly during those, especially during the early times. And then suddenly I'm ambidextrous because at the same time that we're doing the Cerner build, we're doing the rest of the build. And all of that had to move forward and couldn't be left for the last minute. So we were very lucky in the emergency department. We were able to put together a team of Cerner specialists that were RNs and emergency nurses. And this was very productive for us and very necessary to us because we had no end user group to depend on to go out and say, here's what we're bringing in, folks, how it'll work, how do you feel about it? Didn't have that. So we were able to do a pretty good job, and the subject matter experts and the IT analysts that we had did and are still doing just a tremendous job for us. And we had a really smooth opening with our particular net. We were able to learn from others, which was good, but it opened up and worked well. Had to keep in mind the vision of the department and its processes and how that was going to interface with the medical record, the electronic medical record, to make sure that we weren't designing things that were impossible to back up electronically. We needed to decide on our IT equipment and where we were going to locate it, what was the most advantageous for the staff, and what the training programs were going to look like, and how we were going to maintain and improve the program once it was there, and that we're doing that through the use of nurse informaticists and IT support. We also had to keep in mind that there were other major departments on which the emergency department is extremely dependent that were coming up at the same time we were, and that we had other departments in the hospital that we needed to relate to. So the four directors of the major departments coming up sort of formed a group that met as often as we felt necessary with each other outside the normal meeting schedule to make sure that our individual nets would not cross each other up, that we wouldn't start some sort of domino effect as we went along or create problems. We had the big bang versus pop, pop, pop theory of how to start this up, and I used to be a big banger and I've converted. In this case, the staggering starts helped us a lot. If we had opened the whole building and all the departments at the same time, I don't think we would have had as smooth an outcome as we've had. So we had the staggering starts, and we were able to observe other departments as they came up and, learn from anything they had and kind of react to it quickly to bring ourselves out of anything that was similar in ours. We also did what's called a soft opening. In other words, we did not and are only now starting to aggressively market the department to the community. We just basically, on the 26th of March, opened the emergency department doors at 5:30 in the morning and waited for them to come. We've seen more people than we thought we were going to see. We're not seeing but about 50% of what we'll ultimately see over the next few months. So we're up around in the early hundreds right now a day, and they're finding this mostly by themselves or by direction of their doctor or a neighbor and stuff like that. There will be a marketing burst now that's starting right at this time to kind of help push that along. We're monitoring the progress of not only the department, but how we're interfacing with the other departments, and that's real important. And as Melanie mentioned, meetings, we got lots and lots of meetings. And meetings are important, and you can get a lot done there, and you can make decisions and walk away with something done. However, you do need to leave a little room to get it done after you leave the meeting, rather than getting to the next meeting. This campus in itself was a challenge in that the hospital's on one side. The trailers where we originally lived, some of us, were way over here. The management of the hospital's in the tower, and then we had another building over here, and somehow through the use of supercomputers, they were able to manage the meetings so that you made sure that every meeting was on the furthest point from wherever you were. They managed that real well. So, did a lot of walking in those days. That was real good. In focusing on the new, we didn't want to lose sight of the existing processes. We needed to integrate into them and have them, in some cases, integrate with us, and refine our interactions between areas like clinical reporting and who and how you make contacts, and all those things had to be built into there. The command center oversight was very, very important to this. The departments, when you open up, you end up in the trenches. You lose sight of the 10,000 or 50,000 foot view of what's going on. the command center kept that checked. And meeting with the command center, having our huddles, started to bring it all back together. What am I doing that's doing something to you? What are you doing to me? That type of thing, and be able to iron it out right there. So that was extremely important. And then frequent to point-to-point exchanges of information through the meetings, through direct contacts, texting, whatever we could use. We kept that up a lot during that time and still do now. In the operations, once we got open, the main thing was to follow through on the plans. There's always sort of a temptation for people to kind of drift from what they've decided and start to make, diversions in course. And you need to stick with it because you need to know what you're doing is either working or not working. And you can't do that by meandering about all the time. So I've sort of always prescribed to the etch it in mud, not in granite initially, so that you can scribble it out real fast. And the main things you want to do, though, is make sure that everybody can't make a decision to change something every time they want to, which people are apt to do, and that needs to be controlled from the outset. And deciding what the level of harm and disruption and how do you need to communicate and train for it is all important. You need to have predetermined markers, milestones, and data collection so that you actually can make competent decisions rather than anecdotal decisions. And that's always a hard one because when something happens, the anecdotal becomes the rule, and you need to be very careful with that. And then always remain aware of the big picture as you're going along. With the marketing, I'll go over this real fast. We were, decided on the soft, like I explained. We're looking at the audiences. We're actually starting a survey on all our patients to see how they found us now. And then as the marketing goes out, we'll try to see what was the best marketing, what didn't seem to bring anybody in at all, focus on where we need to go, work with the patients and families on this along with the community, get the best bang for the buck and all of that good stuff. Data gathering and to plan and tune, one of the best parts of having an electronic record is that a lot of your data is a lot easier to put together. As you're planning, plan well for the data you want. With most systems, it becomes very expensive and very difficult to get data changed around after you've decided, unless you've got some sort of querying tool that allows you to do it ad hoc. So keep that in mind. And add data points when you see that you need more data points. So you can have a good idea of where you need, but stay flexible enough to pick up anything else you do. No matter how hard you tried to plan, you will always find things that you forgot, didn't work, you didn't know the door opened in instead of out. I mean, there's any number of things that we found. It was amusing at first. As much time as we spent with the place, once people started actually coming through the doors and not people that had already been oriented to different parts of the department, it changed how we looked at certain things. Data helps, anecdotes not so much. So, keep good data. And keep going on and reviewing future plans often, find out if they're still relevant, if you need to change anything, but so that you've got some guidepost out in the future that you can head towards. So that's about it. The opening was good. We're underway. We've been open for about 6 weeks, and we really appreciate all the help we got from the IT side and from everybody that's been involved in this project.
Okay.
Hello, I'm Louise White and have the honour to be the Chief Nursing Officer and Vice President of Patient Care here at CHOC. I think we are running a little out of time, so I will try to be quick. I'm trying to give some oversight here of the broader vision of the project, and we really wanted to transform how we delivered care here. So obviously we started with a vision. What are we trying to become? And we are trying to become a major tertiary center for pediatrics in Orange County in Southern California. You must have knowledgeable leaders if you are going on a project of this magnitude. I think even listening to my colleagues, I don't think they have quite expressed the magnitude of this project. I have done many, many projects in my career. I've really had the privilege of building heart institutes and other buildings that departments have moved into. So I've had a fair bit of experience, but nothing was like this project. This was a project where you opened up the 4 major departments of your hospital other than the inpatient units, with nobody here that knew those departments, no staff that ever worked in those departments, no IT, nothing, and no leadership that had run those departments. And so the magnitude of the project was intense. Bringing on the knowledgeable leadership that really knew how those departments worked and how to do it was essential to the project's success. You're then bringing on 600 staff, you're opening new departments, none of them have worked in those departments, none of them have worked the IT in those departments, so you've got to train everybody incredibly to levels that I have not had to experience before. You also have to understand the culture of the organization. We've onboarded 600 new staff and new leaders and opened up new departments, but we don't have the right to change CHOC culture. We need to emerge ourselves into the present CHOC culture, and we also need the CHOC culture to grow and expand. But doing that and adjusting into cultures is challenging and takes a lot of work. What does the architectural design look like? Did you get it right? Did you get it wrong? How are you going to adjust into the space that's either been designed for you or you have designed? Equipment. Number 1, the day you arrive in a project like this, check all the equipment, particularly if it's been ordered for you. Did they get it right? Did they, is it the same equipment you want now? Equipment in this project, some of it was ordered 6 years ago. And so does that manufacturer exist anymore? There's incredible amounts of work needs to go on around equipment. Staffing, do you have the right people in the right place at the right time? Have you hired the right staff? Are they going to fit into the culture of CHOC? We had to find 600 people who knew pediatrics. Not just adults, not just nurses, not just techs, but pediatrics. And an incredible job was done on getting really good staff. What does IT look like? I came from an institution that had a different IT system, so I came very nervous. I had all these new departments coming up, all these new nets, all this integration, PAC systems, all of the integrations of the new nets into the inpatient clinical documentation system, and probably was a thorn in my CIO's side for quite a while because I just didn't believe it was going to work. I thought they were going to corrupt each other, they were going to fail, there was going to be downtimes, doctors were going to go running out the ER saying, "Don't you ever ask me to document electronically again." I had all sorts of concerns because of previous really challenging experiences. The IT systems worked beautifully. The directors did an incredible job, as did the IT department, on developing these, making sure they integrated, also making sure we had enough server capacity that we didn't go down as we brought up this whole building. You always think you have enough service capacity. Do you? Once you bring up services like this in a new building. Great success. It was a wonderful experience for me, and sorry my CIO for being such a pain. Key stakeholder involvement, physician involvement, key stakeholder involvement all across the board. We did lots of that. Melanie talked to you about our committees and our structures. Physicians, physicians, physicians. It's very hard to get their input. They do not want to engage until they walk through the door and they have to use the system, or find the room, or the bathroom, or the 4x4. So it is incredibly challenging to get the physicians to the table to gain their input, get their involvement. And as the building's going up, is not the time you really want their input. It's too late, so you have to get that ahead of time. And we did a great job of it. We still didn't do enough of it. because there were hundreds of physicians coming into this building and starting to operate. Timelines, make sure your timelines are good, and make sure you have a long enough timeline to bring up all these new departments. We had to bring up the lab. It had to come up and stabilize and work before we could bring up radiology, before we could bring up our operating rooms, before we could bring up our emergency department, our cath labs, etc., etc. So the timelines on the project were very, very important. And make sure you have the financial resources. Everybody throws the money in for the bricks and mortar. Make sure you have enough money for activation. Takes a lot of people, a lot of time, and a lot of money. And if you don't do that right, you don't open up correctly. When you're developing the new IT, I'm speaking to a crowd that knows this better than I do, so, but make sure it's intuitive to your caregivers. Make sure the front lines are going to be able to use it. Make sure they're involved in it. Don't have a management team doing all of this. The frontline staff have to be involved. They come up with incredible just things in general and bits of information that other people just don't think of when they're not delivering patient care. Must be interoperable with other systems, must be integrated into our processes. We need these systems to work for us, not us work for the systems. They must be intelligent use of data. They must be prospective, real-time, relevant information at the point of care. They must meet the user's needs. They must provide them the tools and the information they need to deliver the care. They must try to help us decrease waste, and they must support and drive our decision-making. Anticipate ongoing challenges. Everything takes longer than you expected, so start real early. Getting input from lots of people and making sure they're all comfortable decision making takes a great deal of time. Technology is constantly improving, but cannot keep pace with the user's expectations. We had all sorts of challenges around that, in that on a long project, by the time you get to buy the tools, whether it's IT or whether it's new lights for your operating room, the technology has changed. So the decision you made has to be fluid and has to be ready for change. You may have made the wrong decision, and you have to have the courage to speak up and declare, wrong decision, we've got to make a change. We've got to move in a different direction or make a different decision. Provider interoperability. Make sure that, certainly when you're dealing with your IT tools, that they are functional for everybody involved. Or that your operating room's not being designed for the circulating nurse. It also needs to be designed for the surgeon. Evolution of the processes and stages require evolution of your governance structure, and Melanie talked about that earlier. If your governance structure on a project like this is not working, change it, and change it quickly. And understanding the 50,000-foot view and remembering the effect on the trenches. I'm an executive. I have got to get down to the trenches and make sure that my expectations, whether it be on timeline, ability to do a project, their capacity to take on any more work, is reality driven. The opposite is true for me at an executive level, not to take my stress level down to the operators. In other words, I can be holding this whole building in my head. My manager within one department is only holding that one department in her head. So her stresses are not my stresses. And to make sure that you're not pushing them downwards, that you're motivating, pushing the team forward, constantly forward, constantly forward. But I thought we were done after go live. Well, I've been saying that for the last month. You have to stabilize. Stabilization takes time. And the departments that we opened up and CHOC were all physician-driven procedural type departments, which is a very different beast than inpatient units, where the physicians come and go. They're really nurse-driven units. These are physician-driven units. So physicians have lots of opinions about the unit and how it's working because they're working in it. Very different. And so it does take time to stabilize, and it takes time. You've got to communicate to the physicians particularly and to the staff. This takes time. I think I spent most of my time in the last month going, we've been open a week. Give us more than a week to fix everything. We've only been open a week. Well, we've only been open 2 weeks now. We're getting there. So things, you just need stabilization. Then you need to optimize. So we're up, we're running, we're doing good. Patients are getting care. Our ORs have already done up to 900 cases very successfully, everything from open hearts to brain surgery to PICC lines with no adverse, great patient satisfaction and no negative outcomes. Now we start to figure out how do we make things faster, how do we get things better, and then you start to optimize. You know what would be really neat? Well, I had a lot of that in the last month. And of course, the money's spent, and there's not a lot of money left for the you know what's neat and the scope creep. So everybody wants to, they're so excited, and they want to get in the building, and they want to do stuff, and they want to ask, could I just have this? And televisions have been the biggest request. Everybody wants their own television in their own area. That's an easy one to fix, but scope creep is a real problem because everybody's excited. There's been money, there's been lots of money being spent, physicians, staff, they've been asking for tools, they've been getting them because it's a new building and you're building it. You've got to watch for that, particularly after go live. And Lean Six Sigma for everyone and everything. Try to do Lean if you can. It's a huge project to do Lean on at every level, but we used it quite a bit. CHOC messages. CHOC really started the whole project and did things on a culture of focusing on the quality and the patient and intensive efforts to involve the physicians. The executive understanding of the project and flexibility. You've got to communicate to the executive team, CEOs, COOs, CFOs, in particular on really understanding the project and what this is going to take and the potential costs, the potential resources that are going to be needed. And as the project advances and things change, that they understand what those changes are. And we had a wonderful system for that. The culture needed and transparency, the shared governance across the organization for everything that we worked on, and that we really have to help people be comfortable with change. Change is scary. Although I think we did a really good job of it, that will be, the change and the culture changes and integrations will be going on for months to come. Never assume a thing. If you ever went home and thought, well, I assumed that was happening, never assume anything. Huge project, huge amount of moving parts, things get dropped, people make misses. They're not bad people, it's just a huge volume of work. And the ability to retain all the information and remember everything is very challenging. So never assume, always check. And physician engagement requires extensive planning. You've got to get them to the table, you've got to meet on their terms, you've got to meet in places that they're available to meet. They are the ones, particularly in our project, that are going to be working there, and you've got to work around their needs. So reflecting on the future of informatics. This is a little bit of a dream scheme for me here, and sort of attached to the project and sort of not. But the IT for our future in healthcare, I believe it's got to go mobile. There is not, and I put here lessons learned from the military, and it's a strange thing for a CNO of a pediatric hospital to refer to, but there is not a person on the planet that would think that this was a good practice. Here's the army, they're running across the battlefield. Soldiers lobbing a bomb over here, he shoots a few individuals over here. He runs forward and he makes some more progress, and then his sergeant comes along and he says, here's the laptop, could you just crouch down here and just document what you did? How far did you go? Get onto the site, type it in there, and if you want some more bombs and bullets, could you send in a ticket to the back? And maybe somebody will bring them up. Ridiculous, right? But everybody expects the healthcare workers who are in the battle of disease to do that every 5 minutes. So how do we move our technology to voice activated, visual in your eye, you can keep moving, you can keep working, and it works for you just the way that we need it? What would Florence Nightingale say? The challenge right now, and I'm going to talk as a CNO, in healthcare, is how do you convince this generation of nurses to suffer the pain that they're feeling through electronic documentation? Florence Nightingale, you can tell by my accent, I was trained at the Florence Nightingale School of Nursing, so I'm certainly a Flow fan. But Florence Nightingale established modern nursing. And she had a heck of a time doing that. Clean techniques, reducing infections, trying to get the doctors to comply, trying to get, sorry for the males in the organization, a male-oriented world to accept that what she was saying might have fact. She built nursing schools, she developed modern nursing. It hasn't, and she had a terrible time with it, and we now all thank her for what she did. We've now moved on, and nursing has changed greatly, but not changed that much from the days when she established. It's got more acute, there's more tools, there's more learning. Nurses are advancing. But this is the new age of nursing. And it's nursing learning. How are we going to advance nursing in healthcare using technology and IT? And this generation of nursing and other technologists and caregivers, we're going to suffer through this. The companies are not going to design the IT for us. We're going to have to design this. And it's going to take us 10, 15 years to get it where we want to use it. And we're the generation that are going to be seen as the trailblazers. And we're the generation that 20 years, 30 years from now, the nurses are going, and hopefully doctors are going to turn around and say, thank you, generation, for doing this for us and designing this. So when you're having your challenges or you're getting your pushback from your staff and your various organizations, remember you're the trailblazers. Remember, we're the ones that are going to change IT in healthcare and make it work, make it good for the patients, make it good for the clinicians. And we'll be the tiny versions of Flow for the 2030 generation. Thank you.
Thank you, Louise, for reminding me why I wanted to become a nurse. So we have a few questions we can entertain, and then Shri has, where did Shri go? He's got some members of our California Assembly here that we have the ability to have an interaction with. So do we have any questions for the panel?
Hello. How much involvement did St. Joe's have in the planning?
I took my glasses off, I can't see. St. Joe's was a great partner. They have cared for our kids for, what is it, 40 years? 48 years now. And we really could not have done this project without St. Joe's' collaboration. The parallel process phase of the IT was intense and took a lot of work with their IT department and our IT department to make that all happen. They've been collaborative the whole way through, from staffing to advice to helping if we even forgot something. We were able to run across the road and St. Joe's would have it for us and help us out. So they have been absolutely integral, and on a project of this size, we could never have done it without them. We can't thank them enough.
Thank you. Other questions? Any other questions? Yes.
My question is, once the project was completed, you hired or onboarded like 600 new staff and employees. Where did you get the feedback as far as how you would set up the scenarios? Since most of the employees were new, where did you get like the nursing feedback on how you were going to set up things? Because you were creating something with a non-existent staff population.
That's a good question. Thank you. We actually did have the directors and educators here who are experts in the field, and so certainly we used them. We also, our scenarios are not unique to CHOC. Our scenarios are about the same as everybody else's scenarios. We have sick kids coming in, and so we use the patient care service nurses that are currently at CHOC. We asked for their input. And we also had some consultants here who called HTS that helped us develop some scenarios. And with their experience, they helped us develop some of those scenarios.
Go ahead. Any other questions? Okay.
Hi, my question is just from an informatics standpoint. Do you all have a CMIO?
Yes, we do.
Yes.
Okay, and I'm sure that that person gave a lot of leadership and was instrumental in this process.
He came to us partway through the process, so he was, once he got here, was very much participated, and we had another physician in the room who participated quite a bit as well. So we have a team of several physician informaticists.
Any other questions? If not, I have a question. Having implemented projects like this in the past, did you have any planned benchmarks as far as like patient flow or things that you actually studied in your previous tower and then assess that in a post-go live or a post-activation or opening status?
We actually did. We have key performance indicators that we identified, and we started with about 880, and so we knew that we couldn't manage that. And so we have about 200 key performance indicators that we looked at. St. Joseph's, they've been seeing our patients for 48 years, so we certainly took that advantage and looked at what they've been doing, and then such as ED, Frank certainly knows his benchmarks. We hire directors that know their book of business, and I think that's key, and they could bring that information to us.
Wonderful. Okay. Thank you so much, panel. We'll go ahead and turn this over to Shri, who's going to introduce our